Oh, okay. Can everyone hear us? Okay. Hello, everyone, and a huge welcome live to Radiology Seminars. My name is Omar Saeed. I'm the Education Manager and Partnership here at Radiology Seminars. Now, before we jump in today's masterclass, I have some incredible news that I'm so excited to share with all of you today. So we've been officially been reconfirmed by NHS Commercial as their official training partner for another year running. Now, to be recognized and reconfirmed at this level is the absolute gold standard in clinical education. It speaks to the quality of the faculty, our rigorous standards, and the deep trust the NHS Trust places on us across the country on it every day. I wanted to personally give a massive shout out and a thank you to all our world-class faculty, our dedicated management team, and most of all, to all of you, all our amazing delegates who trust us with this professional development. We are so proud to be the official training partners for another year running, and because we are so thrilled, and you can hear from my voice, because of the reward, I'm going to be jumping back on the screen right after Dr. Jaber's presentation with a special announcement for an exclusive opportunity put together, especially for everyone joining us live today to the end of the seminar. So make sure you stick around until the end. Now, speaking of gold standards and clinical practices, that leads us right into today's topic. I want to ask everyone tuning in just one simple question. Research shows that up to 30% of acute stroke presentation turns out to be mimics. Making the wrong call under the 2 a.m. shift pressure completely changes patient care. To help us eliminate this reporting hesitation once and for all, I'm going to be handing over to our expert and faculty, Dr. Hisham Jaber. Dr. Jaber is a specialist neuroradiologist at the Imaging Academy of Wales. He is widely known for taking complex neuroimaging and turning into clear, step-by-step reporting frameworks you can use on your very next shift. Now, he is also a lead instructor for our flagship Neuroradiology Fellowship, starting from the 15th of September. And two quick housekeeping notes before I hand over to Dr. Hisham Jaber. Drop your questions in the questionnaire chat as we go. And what we'll do is I will try to answer as many questions as possible during the live Q&A. Now, this session is also recorded, and we will provide you with the recording and the link after the session. Okay? So over to you, Dr. Hisham Jaber.
Thank you, Omar. Thank you very much. And thank you for everyone for tuning in and joining us on this session. I'm just going to share my screen first and make sure you can all see my screen. You can see the screen, Omar, yeah?
Yes.
Yes, brilliant. Okay, thank you very much. So stroke mimics are important. As Omar mentioned, recognizing them is very crucial. As he said, around 1 out of 3, it's literally between 15 to 30% of query stroke presentations are actually stroke mimics. They're not strokes. They are something that resembles stroke. Differentiating them from an infarct is very important because this will affect management significantly. As incorrect treatment can be harmful to the patient. Imagine you have a patient who presented with an acute right-sided weakness, for example, and you look at the scan and you see some low density on the left cerebral hemisphere, and it is interpreted as an infarct, while it is in fact an astrocytoma, for example, or something else, something that is not an infarct. And if they thrombolize, if it was reported as a stroke, and it is actually a tumor. And if it gets thrombolized, it can bleed and end up with devastating consequences. Correlation with the clinical picture is very important as well. The time of onset, the way it presents, sometimes the presentation is completely stroke-like presentation. So it comes down to radiology and your experience. Some people say an infarct or a stroke is a negative disease. So you lose something, you lose sensation, patient lose power. You think about it like this, but sometimes an infarct can present as headache. Take, for example, posterior circulation infarcts, cerebellar infarcts, or occipital lobe infarcts. They present as headache because of dissection, and then you get an infarct. So things can merge into each other, and it can be gray, not straightforward sometimes. Imaging approach: if the patient presents with an acute infarct, you're going to approach it with a query with stroke symptoms. You're going to approach it like an infarct. So they will get a plain CT head. These days, they get a plain CT head and a CT angiogram. And if you are in a thrombectomy center, or if the presentation is a bit delayed, they will get a CT perfusion. MRI can be done in certain centers. In our center, we do them the day after or 2 days after, and we have this short or fast stroke protocol, we call it. Only DWI and a T2 sequence, T2 or FLAIR will do. Okay, so straight on into cases. And please, if you have any questions, I'll keep an eye on the chat box. If you have any questions or suggestions, jump in and we'll get to it. Right, so this patient presented with right-sided weakness. So we had a look at his CT and we saw a shallow subdural collection. As you can see vessels here floating between the brain and the skull. Here, these vessels are pushed towards the brain, so there is a shallow subdural collection. It has a similar density to CSF, so we called it a collection. We didn't call it a hematoma. Here we spotted, maybe actually there is loss of gray-white matter differentiation in the frontal lobe anteriorly, a superior frontal gyrus here as well. But this doesn't actually completely fit with the clinical picture. Patient presented with right-sided weakness. These low densities are too anterior. Let me see, can I get a laser? I can get a laser. So these two densities are a bit too anterior for the area of the brain that you'd expect the abnormality to be in. Right. Okay, so just same scan. Patient, we went down lower slide in the CT head, and you can see there is a little bit of swelling in the cerebral hemisphere here on the left compared to the right. You can see the sulci on the right. There is a bit more space on the right. The left cerebral hemisphere is a little bit crowded. So we thought maybe there is an early infarct here. It's developing left MCA infarct that probably showed more effect in the right frontal lobe rather than the parietal lobe at this stage. When I'm just going to go back to the previous slide, because an astute trainee spotted that this venous sinus is a little bit dense. I don't know if it's projecting well on your screen. So for that, they suggested a CT venogram to make sure there is no venous sinus thrombosis, and that showed actually a large clot in the superior sagittal sinus and some of the cortical veins. So a diagnosis of venous sinus thrombosis is made, plus acute infarct in the right frontal lobe or right MCA territory at this stage. Could be venous infarct, and there is a subdural collection. So we have findings, but we can't completely tie everything together at this stage. They started treatment with anticoagulation, gave the patient aspirin, and things moved on. Following night, they asked, this is again just to show you the clot in the superior sagittal sinus. The clinical team asked for a repeat CT head because patient is not improving and the patient is a little bit deteriorating with lower GCS. again, as you can see, some crowding in the left cerebral hemisphere. We have more space on the right. And now this subdural, it looks slightly deeper than the previous scan. And it looks slightly denser. Let's just compare it with the previous scan. So on the right, we have the previous scan. And on the left, I have the new scan. So this subdural is slightly denser on the new scan, and it is slightly deeper as well. So what caused this subdural collection to increase in depth and a little bit in density? Do you have any suggestions? Any answers from the audience at all? Keep an eye on the chat. So two things can possibly cause this. Rebleed, good. Samreen, rebleed. Acute blood will look slightly high in density, denser than this. Aspirin will not cause it. Aspirin is antiplatelet. The patient was put on anticoagulation. So, well, it's not warfarin anymore these days. They do rivaroxaban and all of the ban family, apixaban and all of that. The possibility of blood is there. Yes, correct. But patient is deteriorating. This area here, empyema, Saleh says, infection is a good thing to think of at this stage. Because try and now untie everything together. We have venous sinus thrombosis. We have this collection in the subdural space that is growing in depth, and it is looking slightly denser. Luckily, I had a very, very astute trainee overnight. He thought maybe this is an empyema. Speak to neurosurgeons. He suggested speaking to neurosurgeons. This happened at 11 o'clock at night. So you can all imagine my delight. I am on call. I'm getting ready to go to bed, and now I'm expecting a call from the neurosurgeons asking me to do an MRI head, because if this is an empyema, they will have to drain it tonight. We got the call, we did the MRI, we woke up the MRI radiographer, and we did the MRI. And here you go. This is a DWI sequence, and all of this is restricting, as you can see. So this is subdural empyema. Mahmoud, well done. And Saleh, well done. Empyema, subdural empyema on the left-hand side, and you can see a small subdural empyema as well over the right cerebral hemisphere. And when we scroll down on the DWI sequence, we saw this restricting material in the right maxillary sinus. And on the T2 sequence, I want you to pay very good attention to the cortex of the frontal lobe here on the left. Can you see how bright it is and slightly thicker compared to the cortex on the right? So the cortex of the left frontal lobe is slightly brighter and thicker than the cortex on the right. That's because, unfortunately, this patient was developing cerebritis. Subdural empyema, cerebritis, infection is happening in the left cerebral hemisphere. That's what caused the venous sinus thrombosis. And all of that, remember the restricting material in the maxillary sinus, all of that came from the sinuses. There was sinus infection. And look here at the right frontal sinus. It is completely opacifying, and there, that is the point of entry. So sinusitis eroded through the bone, infective material seeped into the subdural space, caused subdural collection that extended over the left cerebral hemisphere, caused venous sinus thrombosis, and nearly developed cerebritis and cerebral abscess. Luckily, we didn't get to the stage of cerebral abscess. They took the patient straight away, even before I finished my report. I called the neurosurgeons to tell them about the findings. They said, yeah, we looked at the DWI images. The patient is literally on the table. They drained it for him. And he was fine after that. This happened 5 years ago. So patients fine, continue to have follow-ups. And whenever I check on them, whenever I present this case, because it was an interesting case, I go back and check on them, and they are having images, and everything seems fine with them. So infection and venous sinus thrombosis can present with symptoms similar to stroke. So it is a stroke mimic. Okay. Venous infarct can happen with venous sinus thrombosis, so keep that in mind. Please keep that in mind. Okay? Brilliant. Migraines. We've all heard of hemiplegic migraines. These patients present with facial droop. Sometimes they have upper limb weakness, but all of that was preceded by headache. So again, back to the clinical history. Clinical history is very important. CT and MRI can be normal in these situations. And in certain situations, especially in hemiplegic migraine, when you do SWI, when you do an MRI with SWI sequence, you get this hyperemia or venous congestion over the affected side with headache. Seeing non-specific hyperintensities in the white matter, especially in centrum semiovale, especially in anterior distribution, can be seen in patients with chronic migraines. So keep that in mind as well. Right. Okay. With that in mind, this patient presented with confusion, right-sided sensory loss. What do you think is going on? Show me in the chat. Show me your answers. What's going on? Vasogenic edema, encephalitis. So vasogenic edema, or HSV encephalitis. So vasogenic edema is the edema that is around a mass, right? Cytotoxic edema is the edema you expect to see in everything else, including stroke itself. And I'm really happy that some people are saying it could be encephalitis. Good, well done. Don't be deceived by this optical illusion of an apparent hyperdense left MCA. It looks hyperdense because everything around it is low in density. And if you can see here, there is low density that's going up around the basal ganglia. It is sparing the basal ganglia at this stage. And this was indeed a case of encephalitis, most likely herpes or HSV viral encephalitis, because viral encephalitis crosses to the other side. They can hemorrhage, they can bleed, and they can show faint, very faint restriction, not the type of restriction you see in acute infarcts. Good, well done. So HSV or viral encephalitis. I remember I did a stroke job long time ago, and we had a case of viral encephalitis. Patient presented with, if I'm not mistaken, left-sided weakness, did the CT head, showed this low density on the right. Patient was thrombolized, and then they started seizing a few hours later. So the first question that came to our minds, did they bleed because of thrombolysis? We repeated the scan. There was no bleed, but the low density we saw earlier extended a little bit to the frontal lobe on that side and tried to cross to the other side. So we thought, oh, maybe this is viral encephalitis. Managed the seizures and the fits, scanned the patient with MRI, and then we did an LP and confirmed viral encephalitis. So good. Keep that in mind as well. So this is another stroke mimic, encephalitis. Medial temporal lobe involvement, HSV is very common. It's not just the medial temporal lobe. It can affect the brainstem in listeria encephalitis, and brainstem can be affected. The cingulate gyrus, in viral encephalitis specifically, cingulate gyrus is a very common place for it to be involved. So keep that in mind. Keep that in mind, please. All right. What can you see here? Very subtle. I added an arrow. It's very subtle. Low density here in the medial aspect of the right temporal lobe, and we did a DWI. It wasn't restricting. On T2, very subtle swelling and T2 signal change. Okay, and that showed increased perfusion. What does that mean? This is a case, patient presented with confusion, a bit of temperature, swelling of the gyra. Yeah, a bit of temperature. We thought initially maybe it is another case of encephalitis. Yeah, we thought that as well because of the temperature. But someone dipsticked patient's urine and it was positive for nitrates, so they blamed it on a UTI. Brilliant, Samreen. glioma because of the increased perfusion. It's a young patient, unfortunately, in her 30s. We repeated the study. Here we go. We repeated the study. I'll show you 1 second. So this is the MRI. We repeated it, and it showed continued signal change in the temporal lobe, and it didn't. And it could be post-seizure change. Yes, it didn't cross to the other side. Crossing to the other side is a sign of encephalitis. This didn't cross to the other side. And when we did ASL, arterial spin labeling, is a sequence that proves radiologists can see colors, not just gray and white. And it is very useful. I like it. You can use it for so many different things, including dementia. So a high perfusion when you're diagnosing a glioma or brain intracranial malignancy. So Kai, glioma, or high-grade glioma, or GBM, according to WHO classification, you would expect to see central necrosis, but not necessarily in every case. This was a case of high-grade glioma, high-grade astrocytoma, because of the increased perfusion. It didn't show restriction, it didn't show abnormal enhancement, but it behaved in a very aggressive high-grade way. They resected it, and literally 3 months later, it came back. It came back with all of this. So this is a case of high-grade glioma, unfortunately, in this young patient. It came back in an aggressive way. It caused compression on the ventricles and hydrocephalus. Unfortunately, it was diagnosed early in 2023, and by the end of the year, the patient unfortunately passed. I'll pass you on to Omar for a second, and then we'll carry on with the cases.
Thank you, Dr. Deber. So what you're learning today is part of our neuro fellowship. What we try to do is that this small seminar, this whole webinar is there to kind of give the information. Unfortunately, with the constraint of time, we're not able to it's very difficult to kind of learn everything. And that's the reason we have the neuro fellowship. Now, this is a comprehensive, structured, and clinically focused fellowship. And it's intensive learning made practical and manageable. So as it shows on the screen here, it covers the brain, the spine, neck, and head. This is CPD accredited, and official fellowship certifications will be provided as well once the fellowship is completed. And you can earn monthly CPD points and formal fellowship credentials with this. Next slide. One of the advantages of this fellowship is that it's 100% on-demand flexibility, because we know how unpredictable shift work and call rotations are. So the entire fellowship is available on demand, so you can watch, rewatch, and learn whenever it fits your schedule. That's the beauty of the fellowship. On your right, we've given the QR code for this. If anyone's interested, please do kind of scan this QR code and we can send you more information on that as well. Next slide. So one of the things, as part of the fellowship, you also receive monthly live 2 to 3 hours master classes where you deep dive with Dr. Hisham Deber and our other faculty across 10 core brain and spine modules. Now, you also get weekly case discussion modules. We use real-world DICOM case walkthroughs so that it's much more practical to your practice as well. Moving on. One of the things which kind of sets the fellowships apart is that we offer something called the Radiology Seminars community completely free with the fellowship. The community provides instant access to over 100+ consultants across MSK, neuro, cardiac, for peer discussions and second opinions on urgent cases during your daily reporting practice. Now, these are senior consultants spread across the world so you can learn and engage with the experts on the community. Over to you, Dr. Sham.
Oh, someone said the QR code is taking us to funny sites. Can someone sort that out, please? Okay, right. Back to the interesting stuff. PRES. We know PRES, posterior reversible encephalopathy syndrome. It's not always posterior. And it's not always reversible. Keep that in mind. Okay. And so many things can cause it, not just high blood pressure. Low blood pressure can cause it. So blood pressure disequilibrium can cause it. Seizures or seizure medications, patients being on dialysis, so many things can cause PRES. Okay, and this is a case of a 19-year-old patient presented with low GCS after a seizure. So we scan the patient. This is a previous scan for the patient, by the way. This is a 19-year-old patient. This is, oh, hang on, yeah, I'm still sharing my screen. Yes. So on the right is a previous scan for the patient. Yes, gave him septum pellucidum, which is fine, normal variant. Previous scan for the patient. The brain is filling the box, as we say. Looks normal for a 19-year-old. The scan that we did with their acute presentation, it showed significant volume loss. It's not related to PRES, but I just want to show you that sometimes certain anti-epileptic medications can cause cerebral atrophy. So keep that in mind. Phenytoin in the past used to cause significant cerebral atrophy. But it is a differential diagnosis for atrophy. And here you see low density in the left temporal lobe. It's mainly in the subcortical white matter, sparing the cortex, as you can see here, in the parietal lobes bilaterally. So that's the posterior distribution of it. And when you do an MRI, we just do it to confirm, basically, and make sure there isn't any small masses causing edema. And in this case, it was just PRES, posterior reversible encephalopathy syndrome. Hyperintensity in the parietal lobes bilaterally. And that's in the temporal lobe, the one that we saw earlier on that CT head. A repeat study. After roughly 5 weeks, 5 to 6 weeks, all of this signal change disappeared. So the signal change we saw in the parietal lobes previously, it now disappeared. So in this case, it was reversible, but remember, it's not always reversible. Right. Okay, Todd's paralysis, another one to keep in mind. Unfortunately, I don't have a case for this, but I thought I'll mention it because it's a very big stroke mimic, especially patients present with seizures. If they have a bit of temperature, people will straight away think of something else like HSV, encephalitis. It could just be Todd's paralysis, and in Todd's paralysis or post-ictal MRI findings, you see hyperintensity in the cortex, especially the insula. You see that on FLAIR, and it can show restriction as well. Demyelination is a big mimic as well. The new McDonald's criteria for demyelination diagnosis, multiple sclerosis diagnosis, re-included optic nerves. So optic nerves are back on the list as a different location, separate location for multiple sclerosis. Optic nerves and optic chiasm, periventricular white matter, touching the ventricles, juxtacortical, and spinal or infratentorial white matter. These are the locations for hyperintensities. Demyelinating lesions can show you any type of enhancement. Open ring enhancement, or ring enhancement, or solid enhancement. Okay, so don't forget that, because demyelination can look like anything. This is a patient who presented with left trigeminal neuralgia, and they had very subtle juxtacortical lesion here on the left. There is this deep white matter lesion. There were periventricular lesions. And there was a lesion here in the posterior cranial fossa, literally at the origin of the left trigeminal nerve. Multiple sclerosis lesions at the origin of the trigeminal nerves can cause trigeminal neuralgia. That's why if you report cases, trigeminal neuralgia cases, your protocol should include a flare sequence to make sure it's not an inflammatory process, demyelinating process, that is causing the symptoms of trigeminal neuralgia. In this case, there were lesions literally here in the midbrain next to substantia nigra, and literally a periaqueductal lesion here on the left. There is a periventricular lesion, as you can see, in the left frontal white matter. All right. Next, a case of right-sided weakness. We did a CT, we saw low density, we did a DWI, no restriction. We did flare, and we saw this abnormality. What's going on here? What do you think is going on? It's abnormal to start with. Low-grade glioma. MOG, okay. Tumor, astrocytoma. Right, okay. You guys, I mean, some venous infarct could be another venous infarct. Yeah. Patient presented with what? Right-sided weakness. Could be another venous infarct. There were no hyperdense cortical veins around that area. There is swelling, there is signal change, there is no restriction, so it's not an infarct. MOG or MOGAD, they call it. I can't remember what it stands for now. Slipped my head. But MOGAD or MOG antibody syndrome, it likes the optic nerves, it likes the periventricular white matter, it likes the spinal cord, especially the conus. This is a glioma. All of you are jumping to oligodendroglioma, glioma, astrocytoma. I mean, it could be any of those. It's cortically based, so for it to be astrocytoma is less likely than being an oligodendroglioma. A patient was not in a correct age group. There were no calcifications on CT. Not every oligodendroglioma will need a calcification on CT to call it an oligodendroglioma. Oligodendrogliomas, they are classified as grade 2 or grade 3. So grade 2 low grade and grade 3 high grade. And unfortunately, high grade gliomas don't necessarily show radiological high grade features. Now this one, it hasn't been biopsied yet. It's literally hot off the press from the recent MDT discussion. So I don't have a definitive diagnosis for it, but all I know is this is a tumor. Cortically based tumors, you have PXA or ganglio, oligodendroglioma, and DNET, as Samreen mentioned. DNET, they usually look bubbly. They like the temporal lobe, not necessarily, they can happen anywhere, but they like the temporal lobe, but they look bubbly on T2. They have a hyper intense rim on flare. This whole thing is hyper intense on flare. So this is likely a glioma. Most likely it'll end up being an astrocytoma on radiological appearances alone. But again, tumors can cause stroke symptoms. Not always enhancement, not always increased cerebral blood flow. That's for oligodendroglioma. Okay, so oligodendroglioma, whether it's high grade or low grade, it doesn't follow the radiological high grade features. Astros and every other glioma does. Good. Functional disorders, keep that in mind as well. Some patients, they present with functional symptoms. And sometimes they can control it, sometimes they can't. It just happens to them. The scans will be normal, and the clinical history will be full of weird and wonderful things. So with these cases, you have to image, you have to take it all the way through before you end up with a diagnosis of functional disorder. It's a diagnosis of exclusion. Another diagnosis, patients present with sometimes thunderclap headache, sometimes stroke symptoms, young patients, and the history, if they present with thunderclap headache, the history almost always, in my practice at least, post-coital headache. And when you scan them in a specific window, you do CT head, and sometimes you can see subarachnoid hemorrhage. And when you see subarachnoid hemorrhage, what you're going to do next? You're gonna do a CT angiogram, and as Daniel said, RCVS. Okay, you can see this narrowing here in the left MCA M2 segment. There is another narrowing just there. There's probably another one there in that segment above, and here is bilateral, a very tight spot here in the left MCA, and very long segment of narrowing in the right MCA. So RCVS is a condition that you need to scan it timely, so to be able to pick it up. Patients can have headache, can have subarachnoid hemorrhage on CT, and can have normal CTs, can have stroke symptoms, because if this narrowing happened at a critical point with a little bit of low blood pressure, can cause infarcts. So they will present like infarcts, but and they can cause radiological appearances of an infarct. But there are no clots. It's just a vessel spasmed on itself and then it opened again. So it depends how long it stays narrowed and tight. Here we go. Good. CT perfusion. So CTA and CT head, when you report them, obviously take everything together, tie the history together, look at everything, make sure you're following the vessels all the way up and then all the way down. You have 4 vessels in the neck that you need to follow if you're reporting a CT angiogram arch to vertex. Choose one, follow it all the way up, then come down, pick another one and follow it all the way up as well. And after looking at the neck vessels, ruling out dissection, ruling out stenosis or carotid web, make sure you reformat and MIP the images or 3D reformat them if you have that software in your PACS system to look for any circle of Willis aneurysms. You would be surprised by the number of aneurysms that get missed when reporting CT angiogram for a stroke, especially if there is an infarct and there is a large vessel occlusion. People see the occlusion and miss the large aneurysm on the other side. Seizures and migraines can have present as a stroke-like symptoms, but imaging-wise, they can be normal. Okay, so stroke mimics, again, to wrap up everything that gives stroke symptoms, but it's not actually a stroke, and the list is long. The list is long. We only chose a few of them to talk about them. Migraine, seizures, psychological disorder, functional disorder, demyelinating disease, tumors, infections, venous sinus thrombosis, sometimes toxic metabolic conditions. Sometimes CO toxicity to a certain degree can cause low GCS, can cause symptoms. Hypoglycemia is one of the big ones, especially with diabetic patients. So keep an open mind. Saying all of that, still the majority of the patients who present with stroke-like symptoms, they have strokes. Okay, I know we said 1 in 3, but 2/3 of the patients, they have strokes. So please don't miss strokes and focus on these things. We are trying to give you tools so you pick up everything and make sure you don't miss anything, and at the end of the day you help your patient and you are satisfied in what you do. Okay, I always tell my trainees, try and answer the clinical question first. They gave you a specific clinical question. Is there an infarct? Is there a mass? Blah, blah, blah. Try and answer that first, but then look for everything else. Yeah, make sure you have a methodology, you have a technique to look for everything else. Right, very quick quiz. What do you see? Normal or abnormal? Abnormal, clearly, it's on my screen. What is this? Patient presented with right-sided sensory loss. I have some answers. Subdural hematoma. Probably not. Dense left MCA. Could be left MCA infarct. Okay. This is the DWI. What do you think? Infarct or no infarct? Infarct. Someone says encephalitis. There is no restriction. Restriction needs to be bright. What is INF? Sorry, I don't know what INF is. Infarct needs to be completely bright. Okay. This is flare. What are you seeing? What are we looking at? Whoever, people said encephalitis, people said infarct, people said tumor, people said glioma with question mark, tumor. And this was a case of astrocytoma. It was an astrocytoma. Yeah, swelling, no restriction, and low density. Can be tricky, Yeah, can be very tricky. All right. Now, this is a DWI, straight away, DWI. There is restriction, and it is a very bright restriction. But it's bilateral, though. It is bilateral, very symmetrical. You'd be very unlucky to have bilateral infarcts like this in your basal ganglia. Anoxic injury could be, what else? What else could it be? Hypoglycemia could be, CO poisoning could be. Someone got it right. 2 people got it right. 3 people got it right. Okay. So this is a case of CJD. Okay. 4 people got it right. Right. Okay. So this is a case of Creutzfeldt-Jakob disease. Obviously, this patient will not present with stroke-like symptoms, but I like to add it there because the restriction is very remarkable. You get diffusion restriction in the putamen and caudate head bilaterally. You get this hockey stick appearance, very subtle here in the thalamus, the pulvinar of the thalamus, and there is cortical restriction, more so on the left, especially in the insula. Think of CJD, okay? Think of CJD. These patients present with what? Does anyone know? Write it in the chat quickly. Rapidly progressive dementia. They present with rapidly progressive dementia. Good. Rapidly progressive dementia is dementia that progresses, and myoclonus as well, yeah. But mainly it's rapidly progressive dementia. It progresses over months to a year. So usually dementia or cognitive decline in general takes years to show itself. This one is rapid within months. It's very noticeable to the family and friends around the patient. Right, okay, CJD. Next. Easy one. We're going to get a correct answer, all of us. Looks like a trident sign or inverted Maserati sign, as they say. This is your patient. Yeah. It's not called it's not called central pontine myelinolysis anymore. It's central pontine, or it's central or osmotic demyelination. I think osmotic demyelination. It's not central anymore because it can affect different areas, can affect the cerebellum, the thalami. But well done. Again, it's not a stroke presentation, but because of the restriction, I thought I added here. This is a case of a patient in ITU, and there is a very keen junior doctor in the ITU who just started yesterday. So this patient looked at their blood results and they noticed the sodium is very low, 111, decided to give them lots of sodium without telling anyone to impress the consultant, and they corrected their low sodium aggressively and quickly. Osmotic demyelination. All right, what do you think of this? Another DWI, diffusion restriction involving the insula bilaterally, temporal lobe on the left, and the cingulate gyrus. Oh, there are 3 questions here. All right, HSV, venous infarct, encephalitis, HSV, encephalitis. I mentioned to you earlier, and well done to those who paid attention, the cingulate gyrus is a common place, is a place that is well known to be affected by herpes simplex encephalitis. Remember that. Okay, remember that. Good. All right, so we looked at different cases, try to cover a good number of those conditions that can present like a stroke, but they're not strokes. MRI is important. As you can see, we radiologists, we emphasize the importance of MRI. Clinical history is important. Pattern recognition. When I mentioned to you, cingulate gyrus is involved in HSV. Keep an eye for that. You all recognize that. With osmotic demyelination case, you recognize that straight away. So pattern recognition is important. Look at as many scans as you can as many normals as you can. Once normal is printed in your head, spotting abnormalities will be very easy. Yeah, these are the references, and thank you very much for your attention. If you have any questions, please put them in the chat. But otherwise, I think I'm done. Thank you.
Thank you very much, Doctor.
No problem.
Let me share my screen. Just give me 1 minute. So we're getting a lot of questions, and people kind of just coming onto our website. This is the official WhatsApp group for the official WhatsApp official WhatsApp channel. Scan this to open a direct chat to our education team. If you need any help with the registration process or have questions about the curriculum, about the fellowship, or any of our courses, please reach out to us. If you want to discuss with us, help you send your personalized funding letter to get your hospital or trust to pay for this fellowship or for courses, please do kind of reach out as well. We also kind of help. If you want to kind of find out how we can get your entire hospital enrolled with us with the end of the NHS commercial framework, do reach out to our team as well. Now, as for the people who stayed for the entire session, now this is what we're offering for the NHS reward celebration offer tonight. The standard enrollment is £250 a month, or £2,500 for the year. There is a discount if you get enrolled for the entire year. To celebrate our official NHS commercial reward, are you able to see my screen? Have I lost people?
Yes, we can see your screen.
Okay, great. So what we're doing is that we're offering this special code, which is Mimic 20, and you get a further 20% discount for the next 48 hours on all our courses, whether if you're interested in the monthly session or the kind of annual kind of payment. So this the 20% works entire store-wide for all our courses for the next 48 hours. Now, so we're going to open up the session now for the Q&A. If anyone has any questions. Do we have any questions for Dr. Jibber? I guess we have no questions. Well, thank you very much, everyone, for attending today. We will be sending out the recording for this session to everyone who has signed up for the sessions. This is part of our monthly seminars. Please do have a look at our website. We have a lot of upcoming webinars as well. Thank you, everyone, and thank you, Dr. Haber, for taking your time out today. Have a very good evening, everyone.